Alright, this is Brian Wormers recording a lecture on malnutrition for medical surgical nursing at the University of Sioux Falls. So I do want to talk about some of the nutritional recommendations with this and components of a nutritional assessment. I know that your book doesn't do a really good job of talking about malnutrition or nutrition as a whole. It does have a chapter on obesity that you might refer to, but all in all, this is kind of a part of GI on a tangent. So nutritional standards realize that we do have the USDA MyPlate, breaking it into fruits, vegetables, grains, protein, and dairy. Realize that we have to have a cultural awareness. So if they can't eat meat due to religious practices, then we honor that and we work with that. Or if they have to have certain types of food, then we honor that as well. Also be aware of geriatric considerations. Realize that their tastes might change with time, as well as they might have limitations on what they can do. They might need their food thickened or different things like that. So when we do a nutritional assessment, we should kind of check out a lot of different things about this, including what kind of needs does that patient have. Do they have chronic diseases that are increasing the calories that they need? Do they have alcohol abuse? Do they have any recent surgery? Are they having weight loss with this one? So what is their metabolic needs, and has that gone up at all? We do need to plan in their ADLs as part of metabolic needs. We'll have to look at their eating behaviors and recent changes to that. Are they eating more or less? Any difficulty with chewing or swallowing? Do they need supplemental feedings? Are they on any medications to stimulate the appetite, such as periactin or Megace? Or are they on meds to, decrease their stimulation? Do they have any problems with their vitamins? Are they taking supplemental vitamins, zinc, iron, or other things? Assessment-wise, what's their height, weight? What do they normally eat? Any problems with chewing, swallowing, recent changes to their diet? So what's their BMI? What's their skin fold measurements? All those kind of things can help with a nutritional assessment. Clinical manifestations, we can look at their hair. Is it full? Is it full of bounce? Is it dry, brittle? Are their eyes moist and regular, or are they sunken? Are their nails, do they have any pitting in them? Or are they, nice strong nails? Changes in the musculoskeletal systems, weakness, brittle bones, anything like that. Changes in neurological systems related to electrolyte imbalances. So labs to go along with that would be H&H, serum albumin, TS, so thyroid type of thyroids, hormones, cholesterol, electrolytes, all those kind of things can give us some insight into their nutritional assessment. Now, malnutrition is when they're not getting enough, and so this impacts the body systemically, and so you might get muscle wasting, you're going to get decreased activity tolerance, lethargy, intolerance to cold, edema, dry, flaking skin, poor wound healing, and it can even lead to death. Nutritional disorders that can go along with this would be, cancer, kidney disease, neurological disease, calorie deficient, which is marasmus, or kwashiorkor, which is calorie and protein deficient. And so with this one, you're going to see more of the big bellies and stuff like that because they're third spacing. You might also see eating disorders such as anorexia nervosa or bulimia. So when we talk about nutrition, oftentimes we can give total enteral nutrition with this, and so this is either through an NG, a G tube, or an NJ, and so that's feeding them a liquid formula, so to speak, to give them their calories and their nutritional needs. So PEG tubes, G tubes, those kind of things. With any of these things, so if we are refeeding them and they've had malnutrition for a long time, we do have to be very careful about refeeding syndrome, because if they're not used to this stuff, they might have a sharp uptake in their glucose and shifts all their electrolytes around, including potassium, and they can get lots of arrhythmias. And so, where you might have seen this too was in like World War II, people in the concentration camps, and the soldiers that they were helping out, and they fed them very dense rations or candy bars or stuff like that, and it actually really hurt a lot of those patients then. Other things we need to be careful for: tube misplacement and dislodgement that causes aspirations or peritonitis, depending on where it's all going. They can get abdominal distension, nausea, and vomiting. And then, like I said before, with that refeeding, fluid and electrolyte imbalances, especially with the hypophosphatemia, magnesium, hyperkalemia, and calcemic conditions. Parenteral nutrition, so this is your TPN, so we can give their nutrition via the IV route, especially if we're using the GI tract and giving it a rest. So realize that this can be partial or total depending on how much support that they need. This will provide some fluid and some electrolytes. Now your text does have a chapter on obesity that's interesting to read through. It deals with more of the surgical management of this, but realize overweight is having an increased body weight for height compared to standard, up to 10% greater than ideal. Obesity is at least 20% above ideal, and morbid obesity is more than 100% above ideal body weight. So complications of obesity are almost unlimited. We're seeing it cardiovascular-wise, we're seeing it metabolically, we're seeing it respiratory-wise, we're seeing it in a whole host of different things. And so obesity plays a wide impact on health. Some management of this, we do have different diet programs. I'm guessing that you've heard lots of different types of these. There's nutritional therapy that we can give, so providing adequate foods and fluids and electrolytes. Exercise, trying to decrease the weight by burning off more calories. There's drug therapy. Ozempic and Mounjaro are probably some of the ones that you've probably heard most recently. There's behavioral management related to eating and exercise. There are complementary and alternative therapies such as acupuncture, hypnosis, and acupressure. And of course there's surgical management with this. So you can do liposuction where you're physically removing some of the obesity and the fat. Otherwise you can see some of this malabsorption stuff when we're doing gastric banding or gastric bypasses. If they've had surgery, we really have to be careful with them. Provide good airway management, pain management, lots of education. Realize that if they've had the banding or the bypass, that they cannot have large volumes of stuff, and that can actually make them quite upset because they want to start eating after surgery, and realize that that's not going to happen. They're going to get small feedings, like 50 cc's of fluids type of feedings instead of major feedings. We want to look at the surgical site, make sure it's all well intact, make sure that there's no leaks. If they've got mobility issues, you can see the risk factor here for DVT, so sequential compression hose and heparin will be started. We want to watch that urinary catheter, remove that as soon as possible, especially as soon as they start ambulating. And then look for any dumping syndrome, and that's when their body's not absorbing any of the nutrients and it's just coming through as stool. And that concludes this lecture. If you have any questions on malnutrition, please let me know.